Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.
Hello, everyone. Welcome to those of you who are able to join us today during our special edition Lung Cancer Living Room. For those of you who don't know me, I'm Danielle Hicks, Chief Patient Officer here at GoTo Foundation for Lung Cancer. And for those of you who may not be familiar with our Living Room program, it's a support and education series that we've created specifically with patients and caregivers and the entire lung cancer community as a whole in mind, with the goal of bringing to you live and in real time educational talks from key opinion leaders in the lung cancer community in a format and in a language that's really easy to understand. So thank you for joining us. Today, as some of you may have already seen, we will be talking about an important study titled The Epidemiology of Young Lung Cancer. What exactly do we mean by young lung cancer? Is lung cancer different in younger populations? What does epidemiology mean? And what is the importance of people like you participating in studies like this and participating in clinical trials in general? This particular study is being run through GoTo's partner organization, the Addario Lung Cancer Medical Institute, which is a collaborative consortium of academic and community cancer centers from around the globe. Alchemy is committed to catalyzing and accelerating the delivery of new and more effective treatment options for all lung cancer patients. And today we're fortunate to have with us the PIs on the epidemiology study, Dr. Jorge Nieva, who is Associate Professor of Clinical Medicine from the University of Southern California, Norris Comprehensive Cancer Center of Keck Medicine, and Dr. Narjust Duma, Associate Director of the Cancer Care Equity Program, Thoracic Oncologist, Low Center for Thoracic Oncology, Dana-Farber Cancer Institute. I'd like to ask each of them to make brief introductions of themselves and to tell us why lung cancer is an area of interest for them. So, Dr. Duma, do you want to start?
Hi, everyone. As I say, my name is Narjust Duma. I'm currently in Boston, and I have a particular focus in younger women with lung cancer. We hosted a previous living room that focused on women with lung cancer in 2020. And I'm happy to be here today to talk about epidemiology of young lung. The needs of patients change, and they may differ based on gender and age. We all have different journeys and different life phases, and that's what the disease can be differently histologically and also socially. Besides that, a little fact is like seeing those images of the lung cancer or the living rooms, it brings like this missing feeling to me or community, and how we have been able to be physically together for quite some time. And I had to say, I almost tear up seeing that because it was often I would see next to Bonnie and the World Conference on Lung Cancer and just chat with her over time. So I miss all of you tremendously.
Thank you so much, Narjust, for being here with us today. Dr. Nieva, how about you? You want to tell us a little bit about yourself?
Yeah, so I became interested in lung cancer some 20 years ago, and I was an oncology fellow at the time. I was working down in San Diego, and I was impressed at how few therapeutics we had at that time, and how lung cancer affected so many patients so frequently. And I noticed that all the cancer research and all the attention at the time was going to other diseases. And there was cancer funding for lots of different tumor types, but lung cancer seemed to be ignored. And I viewed that as something that needed to be fixed and something that needed more attention. And so when it came time for me to, start applying for grants and writing my own, I said, well, I'm going to do work on lung cancer because this is the disease that has the least amount of funding for every person who is tragically affected by it. And I wanted to make a change.
I love that. I think you speak for all of us in your sort of why behind lung cancer, particularly the amount of patients in the US alone that are diagnosed every year, the lack of funding. The good news is I think a lot of things have happened in the last decade or so. Not enough, but a lot of things. And some of the things we're going to be talking about today are only going to help sort of further that progress. Dr. Duma, can you talk about the importance of lung cancer advocacy, not just from an organizational standpoint, but from patients sort of being advocates out there in the world? Educational programming like the Living Room, both you and Dr. Nieva have so graciously participated in living rooms in the past. What role do advocacy groups, patient advocates, and educational programming play in lung cancer research?
So the first thing is lung cancer advocates and activists are essential for lung cancer research. We couldn't be here today with all the progress that you mentioned, Michelle, without those patients and those caregivers that in many cases volunteer their time to help us design studies that matter. It is necessary for progress. We cannot make progress in lung cancer in silence. We need to make sure that patient advocates and activists are included in all studies. And that is extremely important because they provide the perspective that nobody else can provide. Doesn't matter how many MDs, PhDs you have, the amount of knowledge I have gained for interacting with patient activists and advocates cannot be described or be obtained with any titles or any years in school. They have the unique needs. They are experienced the disease. They are caregivers. So in order to do studies that matter, advocacy is essential. And in all my studies, I have included patient advocates and activists, and every time the study has improved, thanks to the input for patients. We need to not only invite activists and advocates to trials, we need to train and provide our patients, activists, and advocates with honorarium or help. So I'm including in my grants funding because they're volunteer their time. They have limited time. They're fighting a disease, and they still decide to do one of the most selfless things, and is donating their time to be in calls, to be in reading papers, to be reading uh, any projects. So empowerment is extremely important for all patients, advocates, and there is no lung cancer research without patient advocates and activists. There is no good lung cancer research without. And I think every physician should be in contact or interact with a patient advocate because it makes you a better human, a better investigator, and a better physician. I think I couldn't be here today if I wouldn't have been a shepherd by Ivy Elkins and Jill Feldman. That since I was a resident, I told them I want to do these things, and they helped me and guide me. So I think empowerment, but providing guidance. We cannot let our patients advocates just become advocates. We have to guide them and invite them. And that's what studies like this is very important. They're very important because we learn from our interactions with patients. We learn from these clinic visits, but we also learn from the patient advocates that have joined many efforts. So just to summarize in a quick answer, lung cancer activists and advocates are essential for lung cancer research. They're essential for advancing the science of lung cancer. And I think they should be included in all studies and hopefully have some type of compensation for their time.
Yeah, I couldn't agree with you more. I think, and I know Jill and Ivy, and they are amazing advocates. I think a lot of times, especially patients who are newly diagnosed, it's a really scary place and a scary time for them, right? So, even considering becoming an advocate or an activist, to your point, feels sort of way out there, like something they're not necessarily thinking about. And our hope at GoTo is that through programming like the Living Room and other support and education services we have, that we can help, to your point, to empower those patients, to give them that much needed voice, because this is a fairly new thing, bringing the patient voice to things such as research and asking them the questions about what's working for them and what's not working for them, and then helping to kind of shift maybe the way we're doing things so that it does fit more neatly, I guess, into the patient experience. So thank you for that. Dr. Nieva, on that same sort of vein or thread, we're talked a little bit about research. There tends to be a fear as well around participation in things like an epidemiology study or clinical trials in general. Can you talk a little bit about what that process looks like and maybe sort of help to dispel some of maybe the myths out there about participation and what it is?
Absolutely. So the important thing to think about is, when I look back at 1999, I was interviewing to become an oncology trainee, and they brought in an X-ray of a patient whose tumor in the lung had grown. And I asked the person who was interviewing me, what are you going to give this patient next to second-line therapy? And his response was, there is no second-line therapy for lung cancer. That really wasn't that long ago. I don't really consider myself that old. Look at where we are today versus where we were back then. We have made so much progress. We've discovered that lung cancer is not one disease, that there are lots of different variants, and we can come up with targeted therapies for almost all of them. We've been one of the first cancers to broadly apply immunotherapy and make it so that we no longer have to tell every stage 4 lung cancer patient that comes into our office that they can't be cured. We don't do that anymore because we have so many good options. So that progress doesn't happen in a vacuum. That progress happens because we participated and we had clinical trials. And it was the patients who enrolled in those clinical trials with the understanding that, yeah, it's going to have some inconveniences and it's going to have some things that are a little bit uncomfortable. But in doing that, you make the treatment of the next generation of lung cancer patients better. So I think the first part of the clinical trial process is to understand the why. And the why is because we don't get better any other way. And then in terms of what's involved with a clinical trial, the first thing is you get to participate willingly. Nobody enrolls you in a clinical trial against your will. That doesn't happen. So you decide you want to participate in the study after being explained what's involved. Usually you get a document that tells everything that's going to happen, all the potential risks. And usually the risks are spelled out in much longer and more detailed language than any potential benefits. And usually when you think about clinical trials, you think about therapeutic ones. You think about clinical trials where, well, now I'm going to get drug A or drug B, and we're going to find out which is better. Or I'm going to get drug A plus B as opposed to drug A by itself. Those are the types of things that happen in therapeutic trials. But not every clinical trial is a therapeutic trial. Many clinical trials are trials where we're just trying to make observations. We're trying to learn about some process. And for the study that we're going to be talking about today, it's really an observational study where we want people to give us information about themselves so we can amalgamate that information and try to understand things a little bit better about why people get lung cancer, specifically why young people get lung cancer and why non-smokers get lung cancer. But with any clinical trial, there's always rules about who gets to be in it, because we need to study populations that are somewhat narrow, because that gets rid of statistical noise, and it's much easier to see something when you're looking at people that are kind of all alike or all similar to one another. And then we carry out the study activities, and then at the end we analyze the data, and then we end up publishing it in places where people can read about it and hopefully learn about it. And at the end of the day, hopefully we know more about lung cancer when we finish than when we started.
Yeah, thank you for that. I think, first of all, for those watching who have participated in trials in the past, thank you for your participation. Not only for the much needed research and outcomes that it has provided, but for what it has meant for the person who may have come after you, may have been diagnosed after you. And I think we could do an entire living room on clinical trials and what they look like and what it means, and when you should be looking at them or having conversations with your physician about whether or not it's a good time. But that's not why we're here today. Another time, another time. Today, we're talking about, in particular, what Dr. Nieva just kind of hit on was a trial or a study that is not a drug trial or a therapeutic trial. But before we jump into this sort of part two, as I'd like to call it, in the young lung cancer space and alchemy studies. Dr. Nieva, can you talk a little bit about the background and the first study that was done looking specifically at the genomics of young lung cancer and what we found there that sort of led us into this part two?
So a lot of people, when they think about lung cancer, they think about it being as a disease of elderly people. But about 8% of the cases are in people who are under 55, another 2% are people who are under 45. And a lot of lung cancer also occurs in people who never smoked, about 1 in 5 cases. So we wanted to better understand how lung cancer in young people looked different from lung cancer in older people. And we found there were a lot of differences. So one of the things was that the younger patients tended to be non-smokers. The younger patients were more frequently women. And we found that the younger patients, in almost 84% of cases, had actionable biomarkers, things like the EGFR gene or the ALK gene or the ROS1 gene, things that we had good drugs to treat. And that's very different than lung cancer in older people, where you don't as often see those types of changes. So we had this initial understanding: lung cancer in young people is different. It's not something that looks the same as in old people. So then that brought us to the question, why? And that's where we came to the decision to run an epidemiology study.
Do you think that the rate of positive biomarker testing, regardless of what type it may have been, is more frequently found in these younger people because of their lack of smoking history and the carcinogens that are attached to that, lack of prolonged exposure to potentially environmental issues and that sort of thing? Is that what we're kind of looking, or some of the things we're potentially looking to find in sort of the next part two or phase two of this study?
Absolutely. So, one of the things that I think we are gradually getting away from in the field is thinking of lung cancer as one disease. It was in the 1940s where we started to say, oh, there's two types of lung cancer. There's small cell and non-small cell. And we stuck with that non-small cell designation, that's 50 years. And then we said, oh, well, now we've got different types of non-small cell. We're really good now at telling the difference between an adenocarcinoma of the lung and a squamous carcinoma of the lung and a large cell carcinoma of the lung. And we found these groups, but then all the great work that's been done in genomics, we now see that lung cancer really is all these different diseases that are all unique. EGFR lung cancer has different patterns of spread than ALK lung cancer, and it looks different than ROS1 cancers, and different ethnic groups are affected. And with many of these subtypes that are driven by these actionable mutations, they're not in smokers. And we don't know what environmental exposures they had that led to having it. We do know that there's no clear gene for most of these cases. You can't inherit an EGFR mutation. You can't inherit an ALK mutation. Most of these actionable biomarkers that we now have drugs for and we have lots of therapies for, they can't be passed from parent to child. They're lethal during embryogenesis when the baby's in the womb. So these mutations are picked up in life, and they're picked up in life, we think, a little bit early in life. And I'm 51 now, so everything under 51 is early in life. And so we really want to understand why that occurred.
Thank you for that. I want to jump now over to you, Dr. Duma, to talk a little bit about this rising incidence in lung cancer diagnosis, particularly in these younger population. Can you tell us a little bit about the status of that, what that looks like today?
Thank you. So the first is what Jorge mentioned, is that lung cancer is still considered a disease of older white men, but we see that is unfortunately changing. So over the last 10 years, we have seen an increasing number of patients that are younger than 50, younger than 40 years old, getting diagnosed with lung cancer. The percentages vary, but unfortunately, it is an issue that we're seeing not only in the United States, but it has been reported in Europe, France, and Italy. It has been reported in Asia, Japan, and China, as well as the United States and Brazil, in which younger and younger patients are being diagnosed with the disease. We know that the disease is different in this population for several things. First, a good percentage of the patients that are younger than 50 that get diagnosed with lung cancer are women. There is also a good percentage that are of Asian descent. And the majority of the type of lung cancer that happen in younger patients is a type called adenocarcinoma. But it also comes with challenges because we have lung cancer as a stereotype. This is how the patient's supposed to look. And many of us get taught that in medical school. So these younger patients suffer a lot of delays in diagnosis. They're often, told they have asthma. In the case of women, it can be called anxiety. And that delays the diagnosis, making these patients a high risk for being diagnosed as stage 4 or metastatic disease. The challenges are there for all patients with lung cancer, but younger patients with lung cancer have these unique challenges, as well as, the lack of financial stability when you get diagnosed with a fatal disease. Many of young patients have young families, or even in school. So the incidence of young lung cancer is going up across the globe. We have no pinpoint reason why many of these patients of these countries are seeing an increased incidence. In some cases has been related to pollution. In other cases, there is no clear picture. But the problem is that more and more younger patients are dying of the disease. And due to the stigma associated with lung cancer, we don't see a big sign in the news, and we don't see a big sign in the highway about how many young lives we're losing. When we talk about all patients with lung cancer less than 50, we're talking about 13 to 14% patients, which is thousands of them in the United States. So besides the histologic differences, the presentations difference, we also see differences in the psychosocial aspects for these patients. And they tend to be very close to their parents, and the family nucleus is different. So like Dr. Nieva, Jorge mentioned, lung cancer is no one disease, and it will no longer be one disease. It's very different, particularly in these patients. As we talk about young lung, I have to tell you the story of what changed my career completely. So I was at Mayo Clinic in Rochester, and I was being trained to be a phase 1, no tumor specific cancer doctor. That's what my mentors were training me to be. That's what I thought I was going to be, and I wanted to be, until I met a young woman with lung cancer. She was unfortunately diagnosed with advanced stage. And the day I met her, she was by herself in the hospital. The first thing she told me was, "Please do not tell my family." She wanted to keep the diagnosis a secret, and we embarked in this journey together to plan ahead how her family will not find out the diagnosis. And I understood the needs that, as an oncologist, I wasn't used to it. I would see her on Fridays because childcare was easier on Fridays. She had two young kids. And she needed to work full time because she didn't have Medicare. If she stopped working, she would lose her insurance. So meeting that woman was so young, in her mid-30s, that was dealing with a fatal disease and the stigma on top of that, and a healthcare system that was not designed for patients like her, completely changed my career pathway. And that's what I'm talking to you here today about the study and about how lung cancer in young patients is an issue that I wish I can, like, this is what I preach every day, that these patients are delaying diagnosis and the many challenges they face. And I think Jorge also has experience with patients that drives everything that we do. For physician investigators, I think we always can go back to that very special patient that motivate us or help us develop a study or try to help improve their care.
Yeah, you just said a mouthful, and I think it's one of the things that there's such a need. Not only, we talked about the research, but there's also a need for this awareness, right? That anyone can get lung cancer, because you're right, it is such a still heavily stigmatized disease, in spite of the efforts of the medical professionals and advocacy groups and patients alike. And it's particularly a challenge for these younger people because of that stigma, and the delay in diagnosis, I think, is a big one. Especially because our screening guidelines don't cover them right now. So they really are depending on their physicians looking at them and saying, we need to look deeper. Maybe it's not asthma, maybe it's not, pneumonia or bronchitis or something like that. So it's a great challenge, but I think it's also a great opportunity for those watching live or those that will come back and watch this post live to really help sort of spread that word, that anyone can get lung cancer, in order for us to sort of change, flip this on its head and change the dynamic around it. We talked a little bit in the beginning, or we've said multiple times throughout, we say epidemiology, epidemiology, epidemiology. And I think we've sort of touched on, sort of between the lines, what that means. But can you give an overview or description of what exactly an epidemiology study is, and why this type of research in particular is so important when trying to figure out what the heck's going on here?
I'll just say that from the standpoint of epidemiology, I think everybody's become a junior epidemiologist in the last 2 years. And we've all come to know that diseases don't affect people equally, that some people, have been subject to this pandemic, and certain groups are highly affected, and certain groups are not very commonly affected. And really what we're trying to do with this study is really no different, is to understand, why some people get a disease and others don't. And then I'll turn it over to Dr. Duma.
When we talk about epidemiology, we talk about the cancer itself and what happened before the cancer. So we spend a lot of time talking about studies and research that happens to treat the cancer, which is important. But the epidemiology of lung young is trying to get to the root of the problem. Because yes, we need treatments for lung cancer, but we need to understand why the incidence of lung cancer is going up in younger patients. Like my grandma, we always say, and everybody knows me, I cite my grandma more than any paper, is that you always need to find out why is making the soup taste so bad instead of distributing the soup to everybody. I promise it's beautiful in Spanish, the whole phrase. But I promise. I'm just translating it. But the point of the epidemiology study is to understand the root problem. How can we fix what is causing this increased incidence? Yes, treatments are important, but I would prefer to prevent or reduce for patients instead of treating patients. So that's what epidemiology does. It understands the roots and the challenges that these patients may face and potential risk factors that may not be aware. And in a particular group of patients. And something that's very unique about this study is that it doesn't end with the patient. We're trying to understand environmental exposures and everything that's related to that young patient with lung cancer. So let's go back. Let's try to understand what has happened that increase your risk for this disease, because not everybody gets it. And that's what is particularly important to me, is because it will provide information that will guide policy and it will guide further research for these patients.
Yeah, I think it's interesting because in my role and over the last, decade and a half, I've talked to patients and I hear their stories. And I will tell you, 9.5 times out of 10, their big question is, how did I get this? Like, why did this happen to me? And so I think what I hear you're saying, and I want to reiterate for those that are watching, is the purpose of this study, and one of you said it, I can't remember which, was to kind of look back before the cancer started. What happened in your life prior to that diagnosis that may have contributed to the cancer actually activating? And I remember we had Dr. Jeff Oxnard, who used to be at Dana-Farber, and he has moved over into the diagnostic world now. But he came, this was several years ago, and when we were live, and one of the patients in the room, asked that very question, like, who gets lung cancer and who doesn't? How is that? How do we, figure out what might be contributing to that? And at that time, he said, it's literally based on what we know now, it's bad luck. Why does, someone who kind of fits that stigma of the, 80-year-old man who's smoked 3 packs a day for 50 years, right? That to people, I think, sort of, they can kind of go, oh, okay, well, that's probably what contributed. But there can be another 80-year-old man, 6 blocks down the street with the same smoking history who never gets lung cancer. How does that happen, right? What was it that made it happen here and not happen there? Because, and correct me if I'm wrong, and I don't want to go too far down this rabbit hole, but when we're talking about cells and cells dividing and ultimately turning into cancer, that's something that our body kind of takes care of on a regular basis, right? We're constantly having these cells that don't belong, and our immune systems identify them and get rid of them. And then every once in a while, one sort of gets through, right? And ultimately lands and causes a cancer somewhere. Is that sort of a basic lay level understanding of how cancer at least develops in the body, not necessarily how it got there to begin with?
I think that's an appropriate description. I actually even use similar description to my patients, because it's very hard to understand why this happened to me and didn't happen to other people. And I think nobody deserves to get this disease, regardless of your behaviors, regardless of your exposures. But there are some people that are higher risk, and there are some people that don't have the disease, like you mentioned. And that's why epidemiologic studies are important. We have learned so much for epidemiologic studies before that have made us live longer and live better. Like infectious epidemiology studies have, paved the way for HIV research, for example. We also have learned that for other cancer types that increase the risk, like hormonal exposures for some type of cancers. So it is time to move past that smoking curtain. That I call it the smoking curtain, like it used to be the iron curtain for Cold War. We need to pass that, and we need to say, okay, yes, cigarettes contribute. That's an important risk factor, but there has to be more. And I think everybody has been blamed on the cigarettes, but we know that some people can develop lung cancer with 1/4 of smoking that other patients were exposed to. So we have to pass that beyond. And I think it's unique to lung cancer that is always blaming one risk factor, and we haven't studied others. We know about some of them, but I think further research is necessary.
Yeah, I agree. And I think the time is ripe, in particular for lung cancer, when I think about Nixon declaring war on cancer as a whole, over 50 years ago now. And a lot of other cancers have been able to kind of make this upward trajectory. And lung cancer, although we're starting to kind of move up that hill, we're still not quite there yet. But I think patient participation, patient advocacy, patient advocates, or activists played a huge role in that too. So just to kind of swing back to that for a second. Dr. Nieva, can you talk to us a little bit about the description of this epidemiology of young lung cancer study? What specifically in this study are you looking for?
So we're looking for people who got lung cancer when they were young, diagnosed before the age of 40. And we've recognized that this is fundamentally a different type of lung cancer than tobacco-associated lung cancer that primarily affects other people. We need patients who know they have lung cancer. They're adults, but they're under 40 when they were diagnosed, and they've had some molecular profiling of the tumor. We need to know, do you have an EGFR mutation? Do you have an ALK rearrangement? What tumor genomic studies have you had? Because ultimately, we're going to compare the different tumor genomics against one another. And we're going to ask you to do two things. We're going to ask you to fill out a survey, and we're going to ask you to give us a blood specimen. Now, the survey that we're asking you to fill out is long. It takes several hours, but you don't have to do it all at one time. You can break it up, and you can do it in little batches. And you have time to do it. It's not a timed survey or anything like that. But we want to know, who you are, what medical history did you have. We're going to ask lifestyle questions. We're going to want to know about environmental exposures. We're going to ask about diet. We're going to ask about genetic risk factors. We've even got a survey module that your birth mother takes and gives us some information as well. And what we're trying to do is find if there are any associations between developing any one of these actionable genetic abnormalities that caused your lung cancer with anything in your past. So we're going to take data from each patient. We're going to batch them together with other people who have similar cancers, and we're going to make some comparisons. And the hope is that we'll find something. It wasn't until about 1970s before we knew that smoking was causing an epidemic of lung cancer. Lung cancer wasn't very common before the development of machine-rolled cigarettes. And so it took time to make that first association for certain types of lung cancer. But we have these other types of lung cancer that we know smoking probably doesn't have anything to do with it. And so we need to find out why, because just like it was important for us to have tobacco cessation campaigns in the 1980s that started to really turn the tide and make tobacco use less common, there may be other things that we need to do to make lung cancer less common in the future. And maybe it has to do with how we cook food. Maybe it has to do with what other medicines people are taking. Clearly there's something going on with women because for the longest time, even at young ages, lung cancer was more common in men than in women. And now for young people, that's no longer the case. Women now have lung cancer at young ages more commonly than men in wealthy nations. Canada, Denmark, Germany, New Zealand, Netherlands, and the US. These are all countries that have seen that ratio flip. And so there may be something that's happening in the lives of women, and young women in particular, that could be driving this. And we need to find out what that is so that women in the future have the option of mitigating that and trying to have less lung cancer in the next generation than we had in this one.
I'm curious, when you spoke about birth mother's medical history, is that more relevant than maybe a birth father's medical history? If so, why? If not, we just chose this because we think women are more likely to participate?
No, there's a number of cancers that we know about that were associated with maternal exposures. And so, could there be some in utero exposure? Obviously, that wouldn't have a different impact on women than men, most likely, but maybe it would. So we want to see if we can capture that information.
And then the other question I have is around the blood draw. What does that look like for a patient, and what specifically are you looking for in the blood? Is it a one-time blood draw?
So we're just looking for one tube of blood, and the participants in the study have options in terms of how they want it done. We can send you a kit, and you can go have it done at a local laboratory or at your local doctor's office, or we can send a mobile phlebotomist to your home and have the blood draw taken at home, and we're perfectly happy to do that. The kits and the blood that's collected are going to be used for some genetic analysis because, as I said before, these actionable biomarkers, EGFR, ALK, ROS1, these actionable biomarkers are not the thing that's getting inherited when you look at people with family histories. It has to be something else. So we have to look at the other genes that are associated with this one to see if there's any potential inheritable factor that makes you more likely to get an EGFR mutation at some point in your life. So we're going to do some of that analysis ourselves. We're going to provide some of the blood to a number of partners, university professors who are interested in studying this disease further. And we're letting the analysis be done in several different laboratories because different scientists will look at the information and analyze it in a different way. And so we have the potential for several scientists to have a look at the data, do the analysis themselves to see if, looking at things in different ways, maybe we find new associations and learn something.
Yeah, I love the collaborative nature of it and having multiple eyes and opinions and perspectives looking at this. So once some of this comparative analysis is done, will patients have insights into the information that is gathered after they have participated? If so, what might that look like?
So, for the patients, they'll complete the survey, and then they can always contact the Go-To Foundation or Alchemy to see when the data gets analyzed and what it looks like. And we expect that there'll be publications and people will be able to read about the work that was done. And now that may not be for several years down the road. So it's not something where you participate in the survey and then you're going to get back instant results. We have to wait for all the patients to enroll. And when all the patients enroll, we'll take all the survey data and then we'll hand it to the epidemiologists and statisticians who will then go ahead and perform all that analysis. And then we'll see what the findings are, and then we'll report the findings. And if you'd like us to talk about it here in the living room a few years from now, we'd be happy to do that.
I would love that. And I think it just sort of drives home, again, for those watching, the importance of enrollment, right? We need to get this study enrolled. The more quickly that we can enroll it, the more quickly we can send it out for the proper analysis, and then have that information to push back out into our community. So thank you for explaining that. I just want to sort of recap for folks that it's a blood draw, one tube of blood, either at your doctor's office or at home. They can send a phlebotomist, which is someone who takes blood, out to your house to do that for you. There's about 200 questions that can be done at your leisure. You can either sit down and get it all done in one shot, or you can take your time. And it's going over demographics, medical history, lifestyle, environmental risk factors, genetic risk factors, and for those that can get this piece done, your birth mother's medical history. So I think I captured all of that there. If I missed anything, please let me know. Dr. Duma, I'm going to switch to you. We talked a little bit about who's eligible, but can you dive a little bit deeper into that and then let people know how they can enroll and or find out more information if they're interested?
So the study, as we mentioned, is dedicated to these young patients to understand the risk factors that could have induced the disease. So we are recruiting patients that are younger than 40 years of age at the time of lung cancer diagnosis. At this time, due to international regulations and this little pandemic that you have heard has going on for 2 years, the study is based in the United States. And we also focusing in one type of lung cancer, which is non-small cell lung cancer. And you don't have to be in contact with your birth mother to participate in the study. You still can get your information if that information is not available. So I won't want people to feel discouraged not to participate in the study if there is no that way of communicating with your birth mother. And also important is that we need to know the biomarker testing of the disease. Most patients, especially younger patients with lung cancer, should have biomarker testing. And this is important, as Dr. Nieva mentioned, not to understand who you got this disease from, because compared to other cancers, we don't see such a germline or inherited disease with lung cancer, but also to understand the unique characteristics of the disease. Most of what we know about young lung cancer is from outdated data now from the early 2000s. So that will also help us understand the cancer and share the results with oncologists that will be treating patients like this. So I'm going to repeat the quick eligibility criteria. Patients diagnosed with lung cancer before age of 40, no small cell lung cancer, is a United States-based study for now, and to have molecular biomarker testing or genetic testing or genomics testing or next gene sequence testing of the tumor to understand that. And I want to, as we talk about eligibility criteria, I want to close about the importance of this study is because before times, we didn't know that radon, for example, was a risk factor for lung cancer. But large cohort studies and epidemiology studies help us understand that, to a point that people are now required to do radon testing before they buy a house. So we want to understand risk factors, that we change policy and practices. So we measure other gases or other risk factors before they buy a house or before they consider anything. And it's not possible for us to do that based on hypotheses. We need the information for our patients to understand why this epidemic and lung cancer in younger patients is starting to happen.
Thank you, Dr. Duma. Just a couple of clarifying questions. So US-based or resident, we got that. That's pretty self-explanatory. Non-small cell lung cancer, does that include both adenocarcinoma and squamous cell carcinoma?
Yes.
Okay. Diagnosed before the age of 40. So does that mean like 18 to 39, or could you have been 40 when you were diagnosed?
Well, right? Is it mutually exclusive or mutually inclusive? I think 39 years and 11 months and 29 days.
Okay.
That's correct, Dr. Nieva. Can I say that?
That's right. That's right. And if you're not sure, it's like, well, I was diagnosed, I was 40, but I was coughing a little bit before that. We can count those folks in as well.
Or track back symptoms that
Because
might have
what
been.
we talk about, because what we
That's
talk
great.
about, these young patients have long months before diagnosis, and that's what we're accounting for those patients. I have many of my ladies, my patients. I call my patients my ladies sometimes. Have gone through mammograms and many other things before the lung cancer diagnosis, but they have symptoms months before.
Great. And then you said it perfectly, and I think there's probably still some confusion out there in the patient and caregiver world around biomarker testing in general. So does this have to be comprehensive biomarker testing, genetic testing, molecular testing? It's called a multiple different things. And if it does have to be comprehensive, are we talking about a 200 gene panel, a 400 gene panel? How much detail should patients know about their biomarker testing history?
We need to know what the biomarker driver of the cancer is. So if you know you have an EGFR mutation or an ALK rearrangement, if you've had testing and you know what you have, then that's what we need. And if you're not sure, please sign up. We have people in the office. They'll help you get your medical records. They review them, and we sign off on every single case. So if you're not sure if you've had biomarker testing, you probably should be sure. You probably should have had good biomarker testing, particularly if you're a young lung cancer patient. And that's something that but we're not requiring that it be a certain test or a certain brand of test or a certain number of genes. We just need to know that there's been an effort to identify the genomic abnormality that drove the cancer.
Perfect. Thank you for that clarification. And I will reiterate that, and we're going to flash up here on the screen the where to go to find out more information and to talk to somebody on the other end of the line if you have questions about your eligibility, somebody that can help you through sort of the screening process, if you will, to determine whether or not you're eligible, and like I said, to answer any other questions that you may have. So we've got about 5 minutes left, and before I jump into the closing and sort of housekeeping of this, I want to ask both Doctors Nieva and Duma if they have any final thoughts for this this patient population on why they should sign up and participate.
Danielle, I can't work hard enough to make this happen. There is nothing that I can do that will get us this information that I have the power to execute. It's really in the power of the patients. And the GoTo Foundation has done a wonderful job of bringing patients together. And all I can say is that if you want the answer to this question, it's going to have to be the lung cancer patients that make it happen. So if you know someone who had lung cancer and they're under the age of 40 and they've not participated in the study, please encourage them to do so. And we really need help getting the word out there to all the potential patients, because as you said, Danielle, the sooner we get the patients enrolled, the sooner we can answer the question. And I think for most of us, the research can't happen fast enough.
I agree with Jorge, and I think it is time to understand lung cancer in younger patients. This needs to stop being what people think it is, a zebra, something we call in medicine, what something is very rare. It is not. When we're talking about 13 to 15% of patients diagnosed with lung cancer, they're less than 50 years old, that it is a medical emergency and a medical important question. So it's time to stop thinking there's a rare situation is here. We need to understand it, so we need to help our patients and reduce the risk of the disease. The time is now, and we cannot do it without our patients or collaborators. It is impossible.
Thank you, Dr. Duma. I think you both have hit the nail on the head. And I think, like I said, talking with patients over all of these years, a good majority of them want to know what they can do to give back. And I think, or, how they can help. And I think for this, under 40 population, this is a huge opportunity to be part of the solution, to be part of research to help to identify all of the things, or potentially identify all of the things that we've talked about here today. And I think, that also helps to generate the hope around this, right? Being able to say, hey, I did this, and here's what came of it, and here's how I participated. Here's how I, like I said, became part of the solution. So thank you to all of you watching who have already joined the epidemiology of young lung cancer study. And for those of you who will be inspired after seeing this to come back and check it out and maybe learn more and get signed up and engaged. There you can go to alchemy, alcmi.net, that website, and right there under our studies, you can find this one where there's more information and access back to those folks, like I said, on the other end of the line to answer any further questions you may have about this study and how to enroll. I want to give a huge thank you to both Dr. Nieva and Dr. Duma for participating today. Again, in the Lung Cancer Living Room, it's oh so important to continue to educate and empower those people who are diagnosed with lung cancer. So thank you, thank you. I will end with my forever thanks to our generous supporters, without whose support we could not bring this programming to you. Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Foundation Medicine, Genentech, Lilly, Merck, Novartis, Regeneron, Sanofi, and Takeda. Thank you for all of the much needed support.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.